so wide, but there are some specific drugs that we'll be looking at. So my qualifications, I have a Bachelor of Pharmacy, and then at master's level, I specialize in pharmacology and toxicology, and at PhD, I'm finalizing my pharmacology and toxicology. I'm at the last stage, just remaining in the final defense. So I'll be taking you through the pharmacology of these particular agents. So for this particular session, because we had a very short notice, I just want us to look at the principles of oncology, and then in our subsequent classes, I think we'll be covering more the classes. So today I just want to introduce so that you can see what is happening. Look at the principles, and then in subsequent classes we may have some detailed contents to cover. But for today, it will be a very short session. So I know we'll be interacting, at least I've interacted with Faith online. Hope Faith is still the class rep. Faith, are you?
Yes.
So in case of any communication, I'll be making through Faith. And we may be having online classes and also the physical classes, depending on the content. But I'll make sure that we cover everything in good time. So allow me to share. Today I'm going to use a PDF, but in subsequent sessions, I'll be using a PowerPoint presentation. So after the session, I'll also share the notes so that you go through them. Maybe anybody who has a concern or any input on the same? Jekonia, is it okay?
Yes, it's okay.
Okay. So I'll be using my PowerPoint presentation, and then I may have some slight interferences. So I'll be muting for some time, but we'll just proceed. So in case you don't get anything, you just let me know so that I can be able to pardon. Or if there's any point that you want me to clarify, just let me know. You unmute and then just communicate so that I can be able to clarify. Welcome. Welcome. Okay, sorry for that. I'm having some sessions. Okay, let me just start by looking at the principles of oncology. Am I audible from your end?
Yes.
Yes, you're audible. You are. Okay. So if you see me muted, I'll be excusing myself shortly in between the sessions. But this one is going to be a very short session. So when we look at the principles of oncology, we just want to see uh, the characteristics of the cancer cells, and then also see types of therapies that we can be able to give, and just appreciate what is happening in cancer. So in our subsequent lesson, I'll take you to the molecular levels of what is happening so that you can be able to know the targets for our drugs. So in pharmacology, I'll expect you to know the classification of our drugs. Uh, after, because it forms the basis of the exams also, I need you to know the classification of these particular agents. So at least when you are being told about an anti-cancer agent, you should be in a position to classify it. Another thing I also expect from you, which is very key when it comes to pharmacology, is the mechanism of action. So the mechanism of action, that one should be known. The side effects, we are going to look at the general side effects of these particular agents. And also we have some specific side effects as per different drugs and the classes. So we look at the general adverse effects in the introductory part, and then we can also look at the specific side effects when we'll be looking at individual classes. So the specific side effects, those ones you also need to know, because as you know, these anti-cancer agents are very toxic to the cells, and there's no selectivity that is happening between the cancer cells and the host cells. So the side effects, that one is mandatory, because we may introduce some of these particular anti-cancer agents to our patients, and then they reduce the quality of life instead of improving. So we also need to know which type of antimicrobial agents are, sorry, of anti-cancer agents are okay to be utilized. So as I was saying, there are some classes of anti-cancer agents that when you introduce, they're very toxic and they're non-selective to the cell cycle. So they may end up reducing the quality of life of our patients. So we need also to know which ones we can be able to give in the elderly and which one we are not able to give, and which one we can give in particular age groups and the types of uh, cancer. Another one, I will also want you to know the pharmacokinetics of these particular agents so that you know which one can be given by which route. Are they taken orally? Are we using the intravenous route? Are we using the intra-arterial route? Uh, have you looked at the routes of drug administration? Maybe.
Yes, we have written the roots.
Uh, Let me ask Gitau Malaysia.
Yes.
When you are giving anti-cancer agents, which is the most preferred route and why?
Yeah, mostly preferred is IV route
Why?
when you are doing spaghetti because you want these drugs to reach to the targeted cells in high concentration and then as soon as possible.
Explanation is okay. The route, I have some reservations. Timothy, any contribution? Maybe. Timothy? Timothy is muted. Alan? Oh, I see Samuel has typed something. Intra-arterial routes. When we're giving anti-cancer agents, we tend to prefer intra-arterial routes because the arteries are carrying the blood to the target organ. So we want to give our drug to the target organ as opposed to, okay, you'll find that some anti-cancer agents will be saying they're given IV route. But now if we're going to give by the IV route, it will go into the circulation, systemic circulation. So we tend to prefer to use the arterial route so that we give to the target sites, so that our drug are just carried direct to the organ. So it's the most preferred because, as I had said, our anti-cancer agents lack selectivity. So they will not be selective to other non-cancerous cells. So that's why we tend to prefer the arterial route. Although there's some that we are going to give via intravenous route, but it's not the most preferred route. That's why you will find that the quality of life is going to reduce when some of these patients are initiated on cancer agents. So when you talk about cancer, I know you have covered them in other units. So cancer, this one, it just refers to heterogeneous groups of diseases which occurs as a result of impairment of the normal functioning of the genes. So here we are majorly talking of the oncogenes, which are regulating the process of our cell division. So if they lose that particular mechanism to check on the cell division, then you end up having this uncontrolled multiplication of the cells. So subsequently, these particular diseases will lead to genetic damage. So as a result, then we have the characteristics of our cancer cells. What are some of the characteristics of the cancer cells? Based on the types of cell, we may have tumors or what we refer to as the neoplasms. So that is just the other terms that we can be able to use when we are talking about uh, cancer cells, but we are going to look at the specific terms based on the type of cancers that they are going to cause. So these particular tumors, they arise from a single abnormal cell. So this particular cell is the one that will continue dividing, and then as a result, then it's going to affect to the other cells or other tissues. Uh, because our cells now have lost the uncontrolled growth, then they may end up causing pressure or they may invade the local tissues. And as a result, then some of the symptoms that a patient is likely to present with will be as a result of that invading characteristics of our cancer cells. So most of these patients, what will bring them to the hospital is pain, because now they cannot be able to accommodate that particular pain. They'll come into the facility. So pain is the major symptom that is likely to bring these particular patients to the hospital as a result of the the invading of the cancer cells, the local tissues. Sometimes also our cancer cells can be carried into circulation, either in the lymphatic system or in the circulatory system of the blood, to other target organs that are distant. So in such a case, then we say our cancer cells have undergone metastasis. So they metastasize. So these are unique characteristics of these particular cancer cells. So these metastasis can also occur as a result of surgeries. If you're going to perform some surgeries, then you are exposing some of those particular tissues. So it may end spreading to other regions. So you'll see some patients, if after they have undergone surgery, then they tend to have a tendency of the cancer cells moving to other regions as a result of disturbing the cell integrity in those particular organs or tissues. So that's also one unique characteristics of our cancer cells. And in such a case, then the prognosis of our patient is going to be affected. So in carcinogenesis, this is just how the cancer cells are going to come about. So we have some mechanisms by which the cancer cells can come about. So best, because it's normally based majorly on the genetic changes that is going to occur, because we are saying the genes have lost the control over our cells. They can no longer regulate the growth of the cells. So now genetic factors come in, and also environmental factors. Environmental factors here, it means that the environment now is favoring the division of our cancer cells. So these two factors are going to cause the initiation of the cancer cells, because we have said it will generate from one. We only need one single cell to be able to have this particular cancer coming in. So the first step will be initiation, and this one is just a step that involves exposure of the normal cells to a carcinogen. Carcinogen is just a substance that is able to cause cancer, or make the cancerous cells lose the ability to control the division of the cells. So the first one, you need the exposure to come in. So it can even be a disease, it can be environmental factors that like radiations and so many things that come into play. So those particular agents, we refer to them as carcinogens. So an exposure to the normal cells, you find that they come in. And a good example are the radiations that we do have. You may find somebody undergoing those particular several X-rays, and then because of those particular radiations, then they end up having cancer coming in, or even the chemical compounds that we use. For example, some of the compounds that we use on the skin when you're looking about the agents that affect the pigmentation of the skin, they can also trigger these particular types of cancer. And then we have promotion. So promotion is where now you make the environment favorable for your cancer cells to undergo multiplication or division. So you create an environment that is going to favor their growth. So that one we refer to it as promotion. So the environment becomes favorable. And then once the environment has become favorable, then there's that progression that comes in. So they continue proliferating. So the cancer cells continue growing, so that there's invasion into the local tissues, and they can also be able to metastasize. So they can move from one organ to another, or they can be carried in the circulatory system to another region, and then they also continue with their multiplication. So that causes the cancers to spread. So you only need one cell to be able to cause a very serious damage to the body. and then the environment can also affect. So if you create an environment maybe where there's plenty of sugar, it's going to favor the the growth of these particular cancerous cells. So the environment is also very key. So you'll find in some cases now, you advise the patients to reduce the number of sugar they are taking, and also there'll be some restrictions in their diet, so that you are going to deprive the cancer cells of the environment, or the environmental factors that will favor their division. Then we also look at the types of cancer. So our cancers, the tumors that we have can either be benign or malignant. So if we talk about benign, these ones are the ones that are slowly growing, and then they also resemble the normal cells. And one thing about them is that they are localized and they do not cause harm. So a good example is something like the one that occurs in prostate. Prostate, that one can be benign. So you'll find that it will, normal, some patients will just continue carrying out their normal life, and then it is also easy to cure it if it is identified or diagnosed in those particular early stages. And then the other one that we have is the malignant tumor. So this one, it has rapid proliferation characteristics, and it has a typical appearance, and it tends to invade and destroy the surrounding tissues. So this one, it means that it's going to be harmful if it's not controlled. So it also has a tendency of undergoing metastasis. So these are the two types of tumors that we have, the benign and the malignant. So the benign, we are saying it's not harmful, and the malignant one, if it's not well managed, then it can cause harm to the body if it's left untreated. So based on that, then we can look at some of the malignant cancers that we have, so that we can just appreciate them. So we normally have the malignant cancers that can be able to affect the different cells in the body. So we have the solid tumors, and we also have the hematological malignancies. So for the solid tumors, these ones, majorly we have the carcinomas. So these ones are just the cancer or the tumors that affect the epithelial cells. And they include the specific tissue cancers, like the ones that will affect the lungs, the colon, and the breast. Those ones, we refer to them as carcinomas. And then we have the sarcomas. So these ones majorly will affect the connective tissues, such as the bones. So we have things like osteocarcinoma. They can also affect the muscles, and we refer to them as leiomyosarcomas. So those ones, we refer to them as sarcomas. These ones are very common, majorly in immunocompromised patients, for example, in HIV. The sarcomas are very common. And then we may also have hematological malignancies. These ones will majorly affect the blood and the lymphatic system. So if it's the lymphatic system, then we call them lymphomas. So for example, we have the Hodgkin's and then non-Hodgkin's lymphoma. And then for the leukemias, the ones that are affecting the blood formation, so those ones, we may have things like the acute and the chronic myeloid or lymphoids. So those are some of the types of the cancer cells that we have. Up to that point, am I still clear? Am I too fast? Are we still together?
Yes, you're clear.
Okay. So we can look at the causes of cancer, so that we can also appreciate them. So we have several factors that are going to cause the cancer. For example, we have viruses. We have things like Epstein-Barr virus, which is very common for causing things like cervical cancer. We have things like hepatitis B virus. This one, as a professional, then we need vaccination against hepatitis B. This one is very common. When you are dealing with antiviral agents, you saw. And then we also have the human papilloma virus. So these ones can also cause some forms of cancer, majorly the cervical cancer. And then you may also have environmental and occupational exposures. So where you are working can also lead to some of these particular cancers. For example, those guys who are working in radiology department, they normally have gadgets that are going to measure the amount of radiations they're exposed to. So if they get to a certain limit, then they'll be given some off days. So such ionizing radiations can also affect the genes and can lead to some forms of cancer. So we also have the chemicals that we use. For example, our vinyl chloride, the benzenes, asbestos. Currently, you have seen the government prohibiting the roofings that were used in 80s, let's say around 80s, 70s, because they contain asbestos, they have high chances of causing some forms of cancer. So they are linked with some forms of cancer. Even some of the chemicals that we do use in our pharmaceutical industries, they have a tendency of causing cancer if you use them in the high concentrations or the concentrations that are beyond the recommended levels. So we normally have a tendency of accumulating some of these particular compounds, and then they may end up leading to cancer. We also have the lifestyle factors, things like the high fat, low fiber diets, tobacco, ethanol. Ethanol, this one, if you have a tendency of taking high concentration of ethanol, as you know, it's a major cause of the colon cancer. And majorly, if you get that particular type of cancer, the survival rate becomes very minimal, because we are saying some of these particular cancers, when they are not managed at the initial stages, then they complicate. So most of these patients, when you admit them, within 3 days they are gone, because now it's being diagnosed at a very late stage. So such agents can also, the lifestyle factors can also contribute to some forms of cancer. And then medication. So medication, for example, alkylating agents and immunosuppressants. These ones, as we proceed, we'll be looking at the anti-cancer agents themselves. So anti-cancer agents also themselves are carcinogenic. So they have a tendency of also causing the cancers. More so the non-cell cycle specific anti-cancer agents, the alkylating agents. These ones will also have a tendency of causing cancer. So we also have the genetic factors. So you may inherit the mutant genes, and then you also pass them to the offsprings, high chance of them also getting those particular forms of cancer. And then we cancer causing genes, majorly I said the oncogenes. This one is the guy that regulates those particular division. So if they lose their function, then it means that you are going to get those particular some forms of cancer. But we'll look at what happens in the cell before you get those particular cancers, so that you can be able to know the targets of our drug. And then you can also have the defective tumor suppressor genes. So the defective tumor suppressor genes, also if they lose their mechanism, because we need to create and also check on what we are creating. That's what normally happens on the cell division. So excessive activity may lead to some of this particular cancer. Maybe if I just ask a question, which drugs do we have? Agneta, maybe Agneta. Is Agneta in? Agneta? Belinda?
Yes.
Okay, Agneta, maybe just a question. Have you done anti-infective agents?
Yes.
Antimicrobial? Which drug has a tendency to check on the cell on the DNA, so that you do not cause over replication?
Come again.
When you're looking at the mechanism of, let me just frame it. When you're looking at the mechanism of action of antimicrobial agents, you say that we normally have some enzymes that do check the replication of the DNA. Which antimicrobial agent when you give, it can be able to cause the bacteria to lose that particular capacity to check on the replication of the DNA.
Oh yeah, I think topoisomerase.
Topoisomerase. So the topoisomerase, which majorly the topoisomerase 2 and the 4, 2 is the DNA guide. So they also have a tendency of making our DNA to lose that particular ability to undergo replication. So that is what also happens in things like cancer. So if you lose that particular capacity to regulate the replication, then you affect the function and the transcription of the DNA. So in the detective and the diagnosis, then we say that early detection is very critical so that you can be able to treat some cancers. Some cancers, if you detect them at an early age, then you are going to manage them. But if you are going to detect them late, then the quality of life is going to be affected and then it may lead to death. So what are some of the warning signs of this particular cancer? So what we will assist you to know some of the warning signs of this particular cancer agents. So if you have unexplained weight loss, you may also query cancer, fever, but fever now you know this one, you need a more detailed test because most of the infections also present with fever, fatigue. If you have unexplained fatigue, you can also query cancer, pain. Pain, as I said, is the major one. These patients will come to you majorly at those who will be coming late. You may have these patients having used most of the NSAIDs and then they are not improving. So it's good also to check, just do some screening so that you rule out the cancers. And then the skin changes. Apart from the opportunistic infections that occurs in things like HIV, also cancer is a culprit in these particular skin changes. So those ones are the very key is signs that the general signs and symptoms that will lead to you having an impression that this one is a cancer. So you may also have some other signs and symptoms based on the type of cancer. You may have defect in the bowel habits, the bladder function. As you may have a problem with some of the sores healing of the wounds. Majorly in things like the mouth, you may have those particular ulcerations that are persistent. You may also have unusual bleeding. So unusual bleeding, this one may be a sign of some of the hematological malignancies that we do have, some thickening and maybe lumps in the breast. So some of these particular agents in your clinical pharmacy be told that you can be able to palpitate them and just see those particular lumps that are occurring in some other body parts. So you may also have things like warts or the moles coming in. So those particular on the skin, these ones will be very common in patients who are immunosuppressed. They'll be very common in suppressed patients. So guideline for just screening our patients. So it's good to screen everybody. Currently, the goal is just screen everyone because most of these particular people are asymptomatic. And I said, by the time these guys are coming for treatment, it's too late and the cancer has already invaded the local tissues or it has already undergone metastasis. So as a result of them being asymptomatic, then you just need to screen everybody to rule out those types of cancers. So all ages, they need to be screened. So everybody needs to be screened because some of these particular people are asymptomatic. So what are some of the tumor markers? Tumor markers, these are just the biochemical indicators that may show us the presence of our cancer. So you may take serum, plasma, or other body fluids, so that you look at those biochemical indicators just to see if they're in the normal levels, so that they can be able to be an indicator that there's something happening. And majorly in our case here, we are looking at cancer. So in the event you find that this particular serum and plasma or other body fluids are not in the required level, then you may want to do some further screening so that you just be specific and know uh, that it's the cancer that you are dealing with. So some of the common examples of some specific tests that, or by tumor markers that we have the carcinoembryonic antigen. That one we use it for colorectal cancer. We also have the alpha fetoprotein, AFP. That one is majorly when you are looking at hepatocellular carcinomas or hepatoblastomas. And then you can also, the other one is also the prostate-specific antigen, the PSA, for prostate cancer. So another thing that also happens for us to be able to identify these particular cancers, you may have a tumor biopsies, whereby you take some tissues and take them for pathological examination. So some specimens may just be taken so that you go and see if they're cancerous or not. So sometimes this biopsy, when you're going to take them, because it requires some surgical procedures, if the cancer, some cancers may undergo metastasis as a result of these biopsies. So some cancers, if if you are sure it's just cancer, you then initiate treatment. If you are not sure, and you take the biopsies, it may worsen some of these particular cancers. So those pathological analyses will also assist you to evaluate the morphological features of the tissues and the cells, so that you just also know which particular stage the patient is in. You may also have some cell surface markers. You may also want to use the flow cytometry. You did some things in spectroscopy. So those particular spectroscopic methods may be used also to assist us just to know the type of cancer, or to assist us to know the diagnosis. We also have the imaging studies. Currently, the PET scan is the most common or the most effective. The positron emission tomography. So that one, I know you have covered them in those analytical chemistries, MRI, the CT scans, radiography. So those are some of the imaging studies that we can be able to use for diagnosis and also to locate some of the tumors. So just monitor them, and currently it's easy because it's automated. Just use the technology to be able to identify some of these particular tumors. You may also have other laboratory tests that you can be able to do. For example, the most common one is the complete blood count. This one, if you have those particular hematological cancers or malignancies, it's a very good indicator. So even in patient, if you are giving them your anti-cancer agents, it's advisable that you do the complete blood count, so that you just see if the cancer themselves are also causing some bone marrow suppression, because bone marrow suppression will also be an adverse effects of our agents, so that you see if is the patient having some toxicity or they're still okay. So the three basic types of cells that you are going to target here is the white cells, the white blood cells, red blood cells, and then the platelets. So frequently when a patient is on cancer agents, we also need to monitor some of these particular blood cells, majorly the white cells, red blood cells, and platelets. So when you are doing our complete blood count, you may also want to know the absolute neutrophil counts. Uh, Just a minute. So as I was saying, when you want to do some of these particular complete blood counts, the CBC, so you may also want to do an absolute neutrophil count. So this one will just be a measure of the neutrophils in persons who have a defect in those particular white blood cells as an indicator of either the prognosis of your cancer. So the absolute neutrophil count, you can be able to calculate it by taking the white blood cell count and then you multiply by the total neutrophil. Total neutrophil, this one, it means you are taking the segmented neutrophil percentage and the segmented band percentage. So this one will assist you to know the absolute neutrophil count, and it will be an indicator of the prognosis of these particular types of cancer. So they can be listed as polis. So the segmented bands, those ones are the immature polis. So you take a total of them so that you can also know the prognosis. But this one is advanced for you. When you are doing diagnosis is when you can be able to know this. But for you, just know that if those particular blood levels are not okay, the blood cells are not okay, it's an indicator maybe your drug is causing more toxicity, or the patient is not, the prognosis is poor, so the patient is not improving. So there is need for you to review also those particular medication. When it comes to staging, staging is where now you want to place or categorize our patients according to the extent of the disease. So this one will also assist us to know the prognosis of the treatment, the cancer staging. So in cancer staging, we have some types of classifications that we use for staging on our patients. So cancer patients, the first one, we have the TNM classification. TNM, this one, this is how it is done. The T indicates the tumor size. So the tumor size can be anything from 0 to 4, whereby if you have a 0, it indicates there is absence of a tumor. And if it's 4, then it means that the tumor is a very large one in size. So you use that particular range of 0 to 4. And then N will indicate just the extent of regional lymph nodes that are affected. So if it's a 0, then it tells you there's no lymph node involvement. But if there's 3, then it tells you that there's extensive involvement of the lymph nodes. And then the M, that one indicates the metastasis. So it can either be a 0 or a 1. So if it's a 0, there's absence of metastasis. If it's a 1, then there's some metastasis that is taking place. So you can use, for example, the one that I've given, we have T2. So it tells you that the tumor size is at an almost moderate stage, but it's growing. Then we have N1, it tells that there's some lymph node involvement. And then at 0, it tells you that it has not undergone metastasis. So moderate size, limited nodal disease, and no distance metastasis. That's how you do some of the classification. And this one is the most common one that we do use for cancer staging. We also have the AJCC staging. This one is just the American Joint Committee on Cancer Staging. So it borrows more from the first staging, where you place your patient from 0 to 4. So in that particular staging, if it's 0, it shows you that the cancer is at its initial phases, but if it's at 4, then it tells you it's more advanced. If it's something between 2 and 3, then it tells you it's moderate. And then we also have something on survival. Survival for a patient, as I've been mentioning, it depends with the extent of the disease. If the disease has undergone metastasis, survival chances are also low. If it has not undergone metastasis, then it tells you that the chances of survival are okay. And then we also have the cell growth kinetics. So kinetic, as you know, that is just movement. So we have several terms that we use in cell growth kinetics. So we may have cell growth fractions. So this just the proportion of the cells in the region that is dividing. So based on the tumor cells and the normal cells is when we come up with the cell growth fraction. So it's an indicator of how the cancer or at the stage at which the cancer is. And then we also have the cell cycle type. So this one, when we'll be looking, cell cycle time. So this one we'll be looking at it when we want to give some types of drugs, because at some cells cycle, some drugs may be ineffective, and at some other cycle, our drugs may be active, and other drugs may be non-selective to this particular cycle. And then we have the tumor doubling time. So this is just the time taken for the tumor to be able to double in its size. So this one is also based on those particular environmental factors, like the space that is available, nutrition, and then also the blood supply. So if the tumor is big in size, then it means that it has already invaded other tissues. So the time it's going to multiply is going to be minimal as compared to a smaller tumor. So the size also determines. The bigger the size, the less it's going to divide. The smaller the tumor, the higher it's going to divide, because it has some space to multiply. So when it's large in size, the time it doubles is going to reduce, because now there is no space to move to other regions. And then we also have our Bayesian growth curve. So this one is the curve that I'm referring to. So at some at the initial phases, you see there's some rapid growth taking place, and then after some time, then you have that particular plateau coming in. So at that particular point, it tells you there's no growth of your cancer. So it tells you that here now nutrition becomes a factor, environment becomes a factor, and the blood supply also becomes a factor. So it means now that you are creating pressure to the invading tissue. Now here is where things like the pain will come in. And also we have the limit for clinical detection. So at the symptomatic stage, then it tells you it's below our 10 raised to power 9. So that's why it's going to be, as most of the patients are going to be asymptomatic. So the cell number, if they're going to be 10 raised below 10 raised to power 9, when you are doing your count, then it tells you that most of these particular patients may be asymptomatic. So if it's beyond 10 raised to power 9, then it tells you now here the symptoms may come in, and then you end up having